Hello, welcome to the lecture on family planning. When you're counseling patients about contraception, family planning methods, there's some questions that you need to be able to answer for your clients. They may ask, how effective is it? How often do I use it? How does it work? What does it cost? Does it require a prescription? And what are the side effects? And how will it affect my partner? So, is there an ideal contraception? Well, there's lots of things to consider when you're looking at contraception. One is it safe? So, when we're looking at safety concerns, if a woman is breastfeeding, is it going to affect her lactation? If she has high blood pressure, is this going to raise or affect her blood pressure? If she has any systemic illness, is there something that's going to exacerbate a pre-existing condition? And, does she have allergies to whatever's in the contraceptive method? Is it easily available? Well, can you just go to the drugstore and purchase it off the shelf? Or do you have to go to a provider and get a prescription? Economical. How much is it going to cost? And of course, with health insurance now, that kind of takes the prescription methods and makes them a whole lot more easy to be able to buy. But not everybody wants to buy insurance. So, is it economical? Is it acceptable? Does this method jive with the person's individual beliefs, their values, and their sexual behavior? Is it simple to use? How often do you have to think about the method? Is it cumbersome? Are there timing issues? And is it promptly reversible? If someone's just trying to space their children and then they decide they're ready for another baby, is there a lag time in returning to fertility? So, some factors that can affect effectiveness. The frequency of intercourse. If someone's having very, very frequent intercourse, they may want to choose a method that basically is a no-brainer, something that's maybe long-acting. If they don't engage in intercourse very often, they may not want to be bothered with something that they have to take every day or go in for an injection every 3 months, etc. So frequency of intercourse really, really plays into, what the choice is going to be. How motivated are they to prevent pregnancy? What's their understanding of how to use the method? Are they willing to adhere to the method? Does it provide long-term or short-term protection? What is the likelihood of pregnancy for the individual woman and the consistent use of the method? The best method for anyone is the one that is safe and will be used correctly and consistently. Know that when you hear the risk of pregnancy with a particular method, you are likely hearing the risk with perfect use, not with typical use. So there's some things to consider when we're informing patients about choosing a contraceptive method. B is for benefits. We can see that we have a little acronym that's celebrated. B is for benefits, and that's the advantages and the rates of success of a particular method. R for the risks. That's the disadvantages and any kind of problems that it can cause in the future. And it's important that the client knows what the danger signs are of side effects of a particular method. Alternative, what else is available? Inquiries. We want the patient to ask lots of questions. What questions do they have that are really going to help them make an informed choice? Decisions. They can decide to choose something, or they can always change their mind. Decision to stop the method or change methods is acceptable. E is explanation. How does it work? That's where all your patient teaching comes in. You want to make sure that they know what the warning signs are, if there are any with a particular method, when they should come back to the office for a follow-up visit. So it's very important that your clients understand all of these things. And documentation. Remember, the job is never done until the documentation is done. And we want to document all the information that was given and that the client understood the teaching. We're going to start simple and work our way up. We're going to look at non-hormonal methods first. First, we're going to look at coitus interruptus, also known as withdrawal, natural family planning, fertility awareness methods, which under this umbrella is the calendar, basal body temperature, cervical mucus, sympothermal, cycle beads, and then your barrier methods. So we're going to go one by one by one. So coitus interruptus, just kind of realize there's a 27% failure rate with coitus interruptus. And the big thing, since we're talking about STIs this week too, it doesn't protect against STIs or HIV. So those are really key things to realize about coitus interruptus. And for generations, people use this method, and what it basically is withdrawing the penis prior to ejaculation. Okay, here's the problem. Pre-ejaculate fluid may contain sperm. So don't assume that your client knows how to use this method. The penis must be withdrawn, not only from the vagina, but also withdrawn away from the external genitalia. Men are encouraged to urinate prior to a repeated act of intercourse in order to decrease the chance of sperm being present in the pre-ejaculate fluid. So what happens if they forget? Well, to put it bluntly, this method is not very forgiving if not used correctly. The side effects, it may be difficult to accurately time the withdrawal. It may decrease the satisfaction with the sexual experience. And what to report to the provider immediately? Well, if you didn't use the method correctly, and there could be a good chance that you're pregnant. That would be something you'd want to report immediately. Okay, let's talk about the calendar method. The thing about the calendar method, it's really important, how to use it. You really should have regular periods. Realize that ovulation usually occurs about 14 days before the onset of menses, not just in the middle of the cycle. To use it correctly, you abstain 4 days before ovulation to 3 to 4 days after ovulation. So you've got a 7 to 8 day window where the couple should not engage in sexual intercourse. Realize too that eggs are fertile for 24 hours after ovulation and sperm live for 3 days. So that's why that window is what it is. It's not recommended until you have regular cycles if you're going to be using it postpartum. As far as side effects, there's no health side effects, but it may decrease spontaneity because, again, you've got that 7 to 8 day window that you're not supposed to engage in intercourse. It takes time and effort to track your monthly cycle. You cannot begin this method immediately, and you need to track a few cycles for several months to see if you are regular. And what would you report immediately? Well, if you miss a period, because there could be a chance that you are pregnant. The thing about natural family planning is, you really have to be very, very regular, very, very determined, document things thoroughly, and that's when they'll work the best. Now we're going to look at the basal body temperature. So how we use it is it's the lowest body temperature is taken immediately after waking and before getting out of bed. So the lady has a thermometer sitting on her night table. At the time of ovulation, there's a decrease in temperature, about 5/100ths of a degree centigrade. And then there's an increase in temperature with increase in progesterone levels early in the luteal phase, ovulation until menses. The temperature remains elevated for 2 to 4 days before menstruation and then returns to low levels. So some factors that affect basal body temperature are infection, lack of sleep, fatigue, late awakening, anxiety, jet lag, sleeping in a heated waterbed. People still sleep in a heated waterbed. Alcohol consumption the night before can affect it. And again, you have to really look and chart your temperature for several months to look at the pattern. If you forget to take your temperature, you may miss the time that you're ovulating and expose yourself to becoming pregnant. There really are no side effects other than you've got to be very methodical with this. And what would you report to the provider if you miss your period because you could be pregnant? Cervical mucus ovulation detection. What the woman needs to do is recognize and interpret changes in mucus characteristics. Now, that nice, sticky, I call it the come hither mucus, is called spinbarchy, and is the term given to this nice, stringy, elastic characteristic of the cervical mucus during ovulation. Mucus, it's clear, wet, and slippery. And so the way the woman needs to check this is when it's free from sperm, any gels, any blood, or any discharge. Antihistamines can dry the mucus and make it feel more sticky. Sexual arousal can thin the mucus. And for this, a woman has to be comfortable with touching her genital area. What if you forget? Well, you could be ovulating. What are the side effects? It's just being determined and being able to touch your genitalia. What to report to the provider immediately? If you miss your period, you may be pregnant. Sympothermal method. How is it used? It combines two of these non-hormonal methods together. It puts the basal body temperature and the cervical mucus method together to assess what's going on. So, as you can see, you're charting the temperature, you're checking the mucus to look for the spinbarchy, and also looking for things like Mittelschmerz, which is the pain that you get during ovulation. If you forget to check these things, you could become pregnant. There are no side effects, and you can fill in the blanks about what you would want to report to the provider immediately. There are some predictors of ovulation, and realize that a lot of these things for natural family planning can be used both to try to get pregnant as well as to try not to get pregnant. And what we advise clients to do is get the most sticks for your dollar. You may want to shop around. They usually have between 5 and 9 in a pack. We advise the client to start testing on day 11 of her menstrual cycle. If she has a 28-day cycle, she probably will ovulate between day 12 and 16. She can use other fertility awareness to determine when to test. And what it does, it measures the LH surge. So what time of day should we recommend that she tests? They can be used at any time of the day. Some of the manufacturers recommending testing at 2 p.m. or as close to that as possible. It goes with people's circadian rhythms. Anytime between noon and 8 p.m. is fine. Many women experience the LH surge in the morning, but it can take up to 4 hours to show up in your urine. Read specific instructions, but in general, you need to test at the same time each day. Keep testing each day until you detect the hormone surge. To get pregnant, you want to have sex within 38 hours of seeing the surge. To not get pregnant, you want to refrain from sex for 36 hours after seeing the surge. Some medications can interfere with the accuracy, but in general, these predictor kits are 99% accurate in predicting ovulation. Cycle beads. Again, this is a method of fertility awareness, and there's actual beads you can buy as shown here, and there's also an app that you can get for your smartphone. The day a woman starts her cycle, she places the rubber ring on the red bead and moves the ring forward daily. When the ring is on the white beads, there is a likelihood of pregnancy if she has unprotected intercourse. For the app user, the user will receive alerts letting her know she's on a fertile day or a non-fertile day when she's about to get her next period, and to remind her to input her cycle data. She will also be notified if she has a cycle that is outside the range, either too long or too short, and for using this as a family planning method. And it's based on menstrual cycles that are lasting between 28 and 32 days. So So there really are no side effects. I have a link here too if you want to know about cycle beads for your smartphone. And you know what to report to the provider if you miss your period. Barrier methods are non-hormonal. There are several different kinds. We're going to look at each one of these. You have condoms, both male and female. There's spermicides, a diaphragm, cervical cap, and the sponge. A barrier method is any method that obstructs the progress of the sperm. So we're trying to impede that transport. Condoms. One concern that you may have is that you can have a latex allergy, so that's really important. So how is it used? It's placed on the erect penis for the male and placed into the vagina for the female. The biggest concern, as I said, is about latex allergies. Most of them are latex, but some use plastic, some use a non-latex natural rubber. There are some that are made from like lamb intestine. Those are not the greatest to use because they don't protect against STIs. Now the failure rate for the male condoms is about 15%. The failure rate for the female condoms is about 21%. The biggest side effects again are having an allergic reaction or using that lamb cecum that may predispose you to being infected with herpes simplex, Hep B, or HIV because it's not as good a barrier as the latex or the plastic. There should be a disease prevention statement on the label of the condom. One thing that's really, really big when you do teaching is you tell the client not to use oil-based lubricants with condoms because what happens is it degrades that material and makes it more porous, and so instead of being a barrier, it's allowing allowing that barrier to be permeable. They do have an expiration date, so somebody carrying their condom in their wallet for years and years and years, that condom may not be that great when they finally do get a chance to use it. And realize that it's not 100% effective against STIs or HIV. What to report immediately if you miss your period. Spermicides. Spermicides, what they do is they incapacitate the sperm. The active ingredient is naloxone 9, and you can insert it 10 minutes to 1 hour prior to intercourse, but it must be repeated before each active intercourse. It does have a failure rate of about 29%. It can cause vaginal or penile irritation in some persons. And continued use can increase the risk of HIV, chlamydia, GC, and genital lesions just because it's so irritating to the vaginal mucosa. So those are the side effects, and we know what to do what to report any irritation or if you have a missed period. Here's our friend the diaphragm. They're not as popular as they used to be, but it's a very good method for people who don't engage in intercourse very often. So if infrequent intercourse, it's a good method. The failure rate's about 16%. It can be inserted prior to intercourse. You use a spermicide along with the diaphragm. And it's also, sometimes you'll see people call it the diaphragm jelly. And what it is the naloxone 9. You have to leave it in place for at least 6 hours after intercourse. And this is something that has to be fitted by a provider. So you can't just go to, Walgreens and buy this off the shelf. It has to be fitted. It does have some disadvantages. You have to be able to touch your genital area because you have to insert it and remove it. It can be messy with the spermicides. It can cause irritation of the tissue with the spermicides. It puts pressure inside that vaginal wall, so it can cause irritation also on the urethra and cause a urethritis or a cystitis because of the increased pressure. There is a possible risk of increased yeast infections, and women with uterine prolapse or large cystoceles may have have a problem using it. Also, if you have a latex allergy, those are some problems. You know, it's one of these things too that if you forget, you're now having unprotected intercourse and are opening up the door to becoming pregnant. The cervical cap. The cervical cap is it's smaller than your diaphragm, and basically what it does, just like in the diagram here, it's a barrier that fits around the base of the cervix. It remains in place for no less than 8 hours and no more than 48 hours. You want to leave it in place for at least 6 hours after last intercourse. It's used with a spermicide, and again, this is another thing that's fitted by the provider. The failure rate is 32% in parous women, 16% in nulliparous women. The advantage is that is extended wear, so you're using less spermicide. The disadvantage is that it can cause an abnormal pap from the irritation. Women who can't be fitted for existing sizes, they can't use it. They can get toxic shock syndrome. And so anyone with a history of toxic shock should not be using this methods. There can be problems with insertion and removal. It can lead to more vaginal or cervical infections. If you have a strange angle to your uterus, it may be hard for it to stay on. Things that interfere with a good fit is, poor vaginal muscle tone or an unusual shaped cervix that just don't allow it to be fit correctly. The woman should have a repeat pap smear 3 months post insertion. It doesn't cause cervical cancer, but it can give a false positive pap because of cervicitis and irritation to the cervix. So you want to make sure they're not allergic to latex, so in addition to causing problems with an abnormal pap. And things to report to the provider immediately is if she's having any spotting or if she misses her period. The contraceptive sponge is another barrier method. It blocks the cervix and contains a spermicide. It's left in place for at least 6 hours, but no more than 30 hours because of the risk of toxic shock syndrome. It's 84% effective with a 16% failure rate. And remember, again, when we're talking about these failure rates, it's in the perfect world with the person using the method perfectly. Inconsistent use, the failure rate's going to be a whole lot higher. It's not for women allergic to sulfa drugs because it contains a sulfa product in the sponge itself, or if you're allergic to polyurethane or to spermicide. It's not recommended for women who have recently given birth or had pregnancy loss or pelvic surgery, because if that cervix is open, again, you're lending yourself to more chances of having an infection. It's over the counter, so it's available in the United States. For a while it wasn't, and when it was going off the market, I don't know if any of you ever watched Seinfeld reruns, but there was an episode where there was going to be a shortage, and the female character on Seinfeld was hoarding all these sponges, and she would determine if she dated somebody if they were sponge worthy or not. It's not recommended to be used during the menses, again, because that cervix opens up a little bit during menses, and it's going to increase your risk of toxic shock syndrome. So what are you going to report to the provider immediately? Any signs of toxic shock syndrome, we're going to go over that in a little bit. And of course, if you don't get your period. So now we're going to talk about toxic shock. Okay, a small number of cases can happen with the diaphragm or cap. Realize it's a rare but a very, very serious problem. Also, people who leave tampons in, and you would think, who would leave a tampon in? Trust me, people will leave a tampon in for days, weeks, and the results are not pleasant. So when we're looking at toxic shock syndrome, we don't want to use any kind of barrier or obstruction inside the vagina during menses. We want to make sure that with our barrier contraceptives that we take them out 6 to 8 hours after last intercourse. Signs and symptoms are temperatures over 38.4 degrees centigrade, which is 101 Fahrenheit. The person, think of shocks, sudden onset of hypotension. So we're looking at a systolic of 90 millimeters of mercury or less. they'll get orthostatic dizziness and develop a rash. It's the result of toxins produced by Staph aureus, and it can also be caused by group A streptococcus bacteria. Most cases of toxic shock are really seen with tampons, but the risk is like 3 in 100,000 with barrier contraceptives, but the risk is still there and does exist, and we want to make sure we educate our women about these. So now we're going to go and kind of progress to our hormonal methods. We have combination estrogen progesterone contraceptives, also known as the pill, transdermal delivery, progestin-only pills, progestin injection, implantable progestin, the vaginal ring, and emergency contraception. So let's talk about the combination pills. Usually the way the packs come is 21 active pills with 7 days of inactive pills, which are basically usually just little iron pills. There are extended use pills available. It does not act as an abortifacient, which means it does not cause a woman to abort a fertilized egg. It doesn't protect against STIs or HIV. It works by suppressing the action of the hypothalamus and anterior pituitary. Follicles don't mature, and so it inhibits ovulation. The endometrium doesn't thicken and thus is not favorable for implantation. There is a thickening of the cervical mucus, so there is not a favorable environment for the movement of sperm. It works on a 21-day, then 7-day cycle. You have withdrawal bleeding for 1 to 4 days after starting the inactive pills. There is one called seasonal, which is an extended use combination pill, and it's based on 84 days of active pill with 7 days of the inert pills. The advantages are that it's not sex act initiated. It decreases menstrual blood loss and associated anemia. It regulates menstrual problems like irregular cycles. It decreases dysmenorrhea and premenstrual syndrome. It decreases the risk of endometrial and ovarian cancer. It decreases acne problems, and there's less risk taking a pill than there is being pregnant. Contraindications are people who smoke, especially if the patient is over 35, a history of liver disease, if you have an estrogen-dependent tumor, history of thromboembolic diseases, so if you have problems with phlebitis or clots or pulmonary emboli, those things, you should not be using this method of contraception. Anyone with coronary artery disease or cerebral vascular disease, it's contraindicated. Headaches with focal neurological symptoms, it's contraindicated. Anybody who's been lactating for less than 6 weeks, because it can decrease the milk supply. Hypertense women with blood pressures over 160 over 100. Diabetes of greater than 20 years duration. And there's lots of guidelines that come with the pack, with the inserts from the particular manufacturer's recommendations. Medications that can affect the combined pills are anticonvulsants, griseofulvin, which is an antifungal, or rifampin, which is an antibiotic. Evidence-based research shows no decrease in effectiveness with the combined oral contraceptives and broad-spectrum antibiotics, but there are anecdotal reports of people getting pregnant while on antibiotics while taking their oral contraceptive pill. Fertility resumes immediately after cessation of the pill, and there's no associated risk of birth defects. There's all different kinds. There's monophasic, which is the same amount of estrogen and progesterone every day. There's biphasic, which delivers the same amount of estrogen every day for the first 21 days of the cycle. And then the progesterone level is different during the second half of the cycle. Then there's triphasic, which has got changing estrogen concentrations with varying progestins. So just realize that there's different combinations that are along with these. If you forget, then you take 2 on the day that you miss. So you can take, as soon as you realize it, take the second pill. The side effects, again, are it can make you more prone to having blood clots. And what you provide to the provider immediately any unusual spotting, bleeding, pains in your calves. And there's a little an acronym that I'm going to give you too about things to remember and things to report. Transdermal system, what this is it's a patch that has the combination of estrogen and progesterone that the woman applies for 3 weeks and then removes it for a week. It avoids the first pass effect, which refers to the elimination that occurs when a drug is first absorbed from the intestine and passes through the liver via the portal circulation. Because the liver is the primary drug metabolizing organ of the body, drugs are easily metabolized and have a large first pass effect, and low bioavailability. So the transdermal system may expose the woman to 60% more estrogen than a 35 microgram oral contraceptive pill. So it's applied to the lower abdomen, upper outer arm, buttocks, and upper torso, but not the breast area. So we don't stick it on our breasts. And it needs to be prescribed by a provider. So we're going to talk about different things to report when we talk about the hormonal issues. The NuvaRing is a combined contraceptive. It's inserted for 3 weeks. It's removed for 1 week, which time menses occurs. It doesn't have to be fitted. The woman needs to be taught how to insert it. It gets twisted into a figure 8, or they can use a tampon applicator. It needs to be provider prescribed, and it's now approved for extended use. The progestin-only pills, you have Micronor, which is also called the mini pill. It's a very good option for breastfeeding women because it does not affect their milk supply. It inhibits ovulation. It thickens the cervical mucus. It thins the endometrium. It slows the cilia action in the tubes. You have to use it at the same time every day. There's no forgiveness with this pill. If you are more than 3 hours late taking the pill, you are not protected. I mean, you've got to be really regimented taking this pill. And so if you miss a pill, if you're more than 3 hours late, you have to use a backup method for 2 days as you resume taking the pill. You have injected progestin, which is also known as the Depo-Provera shot or the Depo shot. There's no estrogen in it. You get an IM injection every 12 weeks. If you're administering this, we don't massage the injection site because it interferes with absorption. It can alter the blood glucose. There is a concern over bone density, and because it can make the woman osteopenic, and we recommend calcium supplements with the use of Depo. It can cause irregular bleeding, and generally this will be resolved by the second injection. Typically it causes amenorrhea, and the return to fertility can be delayed with the use of this method. Prolonged use, as I said, it can decrease bone density, and we do recommend that the woman not exceed 2 years without being informed of the side effects of this particular method. We also have implantable progestins. There was an old method called Norplant that had 6 rods that were inserted, but now we've gotten great. All we have is a single rod that gets inserted. It's Implanon and Nexplanon. Implanon is the older method, but some women still have this method in. Nexplanon works the exact same way, except the little insert is actually radio opaque, so you can actually visualize it if you need to remove it. It's inserted subdermally into the non-dominant upper arm under local. The side effects are it can cause irregular bleeding. Bleeding pattern usually stabilizes after 3 months. It can be left in for 3 years, and when you take it out, the return to fertility is immediate. So we're talking about all the things with hormonal methods. What needs to get reported? Abdominal pain, because it can cause clots in the liver. Chest pain, shortness of breath. Headache changes. eye problems, severe leg pain. So these are the warnings for people using hormonal methods, and it spells aches. There also is the emergency contraception. When unprotected intercourse has occurred and within 72 hours, this is when you want to use it. It's not an abortifacient, so if you have a fertilized ovum, it's not going to cause you to abort it. What it is increased doses of oral contraceptives. So it's like being pregnant. It gives you more nausea and vomiting. That's the big side effect. And it is controversial, and some pharmacists just will not fill it because of their own personal beliefs. If taken before ovulation, it can suppress follicular development. It is ineffective in women who are pregnant. And the things that you want to report is if you have no menses within 21 days after taking the emergency contraceptive, you need to follow up with a health provider because you could be pregnant. This is the intrauterine device system that can be used. There's several different types. One is the copper T or Paragard. It can be left in for 10 years. The Mirena is 5 years. These are long-term methods that are reversible. They must be in provider inserted and removed. The woman may have irregular bleeding. She needs to check for the string after each menses because it can get expelled or it can travel up. The copper T damages the sperm, so less sperm reaches the tubes for fertilization, and it thickens the cervical mucus. So it doesn't have hormone in it, it's got just copper. The Mirena has progestin in it. It thins the endometrium and thickens the cervical mucus. There's less blood loss during menstruation, and there is a decrease in primary dysmenorrhea with the use of the Mirena. Contraindications: anyone with a history of pelvic inflammatory disease, known or suspected pregnancy, undiagnosed genital bleeding, suspected genital malignancy, a distorted uterine cavity, if they have like a bicornate uterus, a septum in the middle of their uterus. The disadvantages are it does increase the risk of pelvic inflammatory disease 20 days post-insertion. So, a woman really has to be careful about not getting exposed to STIs. There is a risk of bacterial vaginitis with it. It can cause uterine perforation, and it does not offer any protection against STIs or HIVs. The ideal candidate for this is a woman who wants long-term contraception in a monogamous relationship. So what are we going to report to the provider? If the period is late or if there's abnormal bleeding, if there's abdominal pain, has this thing migrated, if she's been exposed to infections, if she's just not feeling well, feeling flu-like symptoms, and the string, is it missing? Is it shorter? Is it longer? So this is the things you report with IUDs. For those who want a permanent method of family planning, then we talk about sterilization. We can do for male and female. For females, about half of the female sterilizations are performed after delivery. For females, there is federal funding available if the client's at least 21 years of age, and there is a 30-day waiting period after signing consent. So, in antepartum clinics, if a woman's desiring a postpartum tubal ligation, she's on Medicaid, she has to have that consigned at least 30 days before she delivers, which means if she goes into labor early and has a preterm baby, that consent is not in effect, and she can't have her tubal ligation, and she's going to have to come back postpartum to have her tubal ligation done. With women with that bilateral tubal ligation, the tubes are cut and tied. They can also do a tubal occlusion, which they do electrocautery or use bands and clips. There's also a device called an Essure. It's a device that kind of looks like a little spring, and what they do is they insert it into the tube through hysteroscopy, and it can be done in the office for outpatient surgery. There is some controversy with it now, with women having side effects, and so it has a black box warning with it. Now realize that if we, typically we try to advise people that this is not reversible. Just say the woman she meets somebody else and she wants to have more babies, that it's very hard to reverse. It can be done. It's microsurgery. It's very expensive. It will increase her risk of having an ectopic pregnancy, which is a pregnancy implanted in the fallopian tubes or up in the abdominal cavity, but not in the uterus. And usually those reversals are not covered by insurance or Medicaid. The male sterilization is called a vasectomy. It's done in the office with local anesthetic. Small incisions made and the vas deferens is clipped. Ice is to the area for the recovery period. Sterility is not immediate. With a woman, when she has that tubal ligation, she's immediately sterile. With a man, it takes about 20 ejaculations before there's no sperm in the ejaculate. And so the man needs to come back to his healthcare provider and should have 2 consecutive negative counts. So he'll do a sperm count. So it has to be no sperm in the ejaculate. It doesn't affect his potency or ejaculate volume. It just does not allow the sperm to get to the ejaculate because we have blocked the vas deferens. So it keeps the sperm out of the seminal fluid. It can be reconstructed, but a lot of times what happens, he may have developed antibodies that attack the sperm. It may make permanent changes in the testes that decrease fertility by not having the vas deferens connected correctly. And it's, one of the greatest risks with either type of permanent sterilization is the risk of regret. So being sorry that you made the decision that you made. So it's real important that when we're talking about permanent methods of sterilization, that informed consent is so paramount. Spousal consent is not required, but it's important that both parties agree that, yes, indeed, they want to go through this. You can't sterilize minors or mentally incompetent people. It's against the law. The explanation of the risks and benefits really need to be understood by the clients, and you have to have a translator. The consent has to be in the language of the client if they're not English speaking. And so you really need a medical translator. You can't use their cousin to translate because that's not going to be very effective. We're just going to talk very briefly about termination of pregnancy. An elective is at the woman's request. A therapeutic is for the preservation of the life or health of the mother, genetic disorders of the fetus, or after a fetal demise, or after rape or incest. Know the laws of the state that you're practicing in regarding abortion counseling. They may have mandates that delay or state-directed counseling before receiving an abortion. Complications tend to be low within the first trimester, and many clients experience a post-abortion depression. In the first trimester, usually these are done during the first 7 weeks of pregnancy. Some clinics will go up to 9 weeks. They'll use a drug to block progesterone, which will alter the endometrium if they're using the RU486. 1 to 3 days later, the patient takes an oral or vaginal prostaglandin, which induces contractions. After 14 days, they need to be seen to confirm if the drugs have been effective. So what they'll do is a beta HCG level to see if it's gone down. If the client has stomach pains, weakness, nausea, vomiting, or diarrhea with or without fever in the first 24 hours, she's to call the provider immediately. With the surgical interruption, the vacuum curettage, the cervix is dilated mechanically with a laminaria, which is it's a sterile seaweed, or with an instrumentation, or by the use of a prostaglandin. Then a cannula is placed into the uterus, and the procedure is done through a vacuum. Risks include uterine perforation. You can have lacerations to the cervix. You can have hemorrhage, and you can have infection. The second trimester termination goes up through 20 weeks. Typically what you'll see is there's two different things. Again, you can use the use of the mifepristone and the misoprostol together. You can use prostaglandins. And years ago they used to use intraamniotic saline, which is rarely used. Typically the most common procedure is the dilation and evacuation, which is usually opted for because it's actually less expensive than using the mifepristone and misoprostol. So what do we need to know about taking care of these clients? Caring for the clients physically. Like anybody going through any other procedure, we want to monitor vital signs and intake and output, the amount of bleeding the patient's experiencing, and doing a pain assessment and intervening for pain. Psychosocial, we want to encourage our client to verbalize feelings and assess the need for further supporting counseling post-procedure. Teaching, self-care, what they need to do when they go home, when they need to follow up with the provider, signs and symptoms of infection that they need to report immediately, and going over available methods of contraception. If you have any questions, please don't hesitate to drop me an email or stop by my office, and I'll be glad to answer your questions. Thank you.